Imagine walking into a dealership, right? You buy a brand new car, but for some completely inexplicable reason, the manufacturer decided to name the entire vehicle after the tires.
Right.
So you drive it off the lot. A week later, the engine is overheating, the transmission is slipping, and I don't know, the air conditioning is totally dead.
Sounds like a nightmare.
Right. You drag it to a mechanic, and they just look at you, look at the wheels, and say, well, the tires look fine, so I really don't know what to tell you. Maybe just try driving it differently.
Which is just, I mean, it's completely absurd.
It's so absurd.
Yeah.
But when you look at the medical sources we are exploring today, that is essentially the reality for, millions of people who are navigating this massive diagnostic blind spot.
Yeah, it really is the perfect framing. It's exactly what happens when the medical field gets just so fixated on a localized label that the whole systemic engine is completely ignored.
Welcome to today's deep dive into the source material. We are looking at this huge stack of documents, global consensus guidelines, specific randomized control trials, major updates to clinical standards of care regarding polycystic ovary syndrome, or, PCOS.
Yeah.
And whether you are personally navigating this condition, or maybe you know someone who is, or honestly, if you're just fiercely curious about how medical science actually self-corrects over time, this discussion is going to fundamentally change how you view the human body.
It really will.
Our mission today is to understand why a condition named after the ovaries is, well, it's actually a complex, full-body metabolic puzzle. Okay, let's unpack this. Why is the name such a problem?
So the name Polycystic Ovary Syndrome is just this classic case of historical misdirection. I mean, it focuses entirely on a single symptom.
The cysts.
Exactly, the appearance of small cysts, which are actually just stalled follicles on the ovaries during an ultrasound. But the documents we're analyzing, they paint a completely different picture. The reality of this syndrome is that it's characterized by androgen excess. So the body is producing higher levels of hormones like testosterone.
Which you wouldn't expect from an ovary issue.
Right, and it involves deeply irregular or just completely absent menstrual periods. But perhaps most importantly, it's driven by profound cardiometabolic dysfunction.
Wow.
It's happening everywhere in the body, not just in the pelvis.
And naming this after the ovaries, like naming the car after the tires, it has real-world daily consequences for the people living with it.
Oh, absolutely.
Like, there's this specific cross-sectional study highlighted in the text. They compared 134 women with PCOS against 198 control subjects without it. And the result is just a stark reflection of that car and tires analogy.
Yeah, the trust gap is huge.
It is. The patients with PCOS reported having significantly less trust in their primary care providers. They actually argue with their doctors more frequently.
Wow.
And they perceive those doctors as far less qualified to actually treat their health concerns.
What's fascinating here is, well, the underlying psychology of that friction. If you really dissect it, those patients aren't just being arbitrarily difficult.
Right. They're not just complaining to complain.
Exactly. Their daily lived experience of their own biology directly contradicts the narrow label they've been given. A patient will go into a clinic experiencing uncontrollable weight gain, profound fatigue, cystic acne, or unwanted facial hair growth.
Right. Full body stuff.
And for decades, the standard medical response was essentially to treat it as a localized fertility issue. The patient intrinsically knows their entire system is malfunctioning, but the label just completely dismisses that reality.
It's a staggering disconnect. I mean, being told that your systemic symptoms are unrelated to your localized diagnosis, that would inevitably erode your trust in the person treating you.
Which brings us to a major shift detailed in the guidelines. After this huge global consensus process, a consortium of experts is actively pushing to abandon the term PCOS entirely.
Right, entirely.
Entirely. They want to rename it PMOS. Polyendocrine Metabolic Ovarian Syndrome.
Polyendocrine metabolic ovarian syndrome. Wow. That is definitely a mouthful.
It is, yeah.
But it completely changes the diagnostic lens, right? Polyendocrine tells you multiple hormone systems are involved. Metabolic tells you the body's energy processing is involved. It finally describes the entire vehicle.
Exactly. And adopting that name, it forces a clinical pivot. Doctors have to look beyond the reproductive system. And honestly, it validates the frustration patients have felt for years.
It's like the medical community officially saying, you were right, this was a systemic issue all along.
Exactly.
So, okay, if we are dealing with a full-body endocrine issue, how does a doctor actually treat that whole system when a patient isn't trying to get pregnant?
Right, everyday maintenance.
Yeah, if someone's just trying to live their life, find some relief. The sources point to a daily strategy that I think might surprise people. Because the absolute first-line therapy is combined estrogen, progestin, oral contraceptives.
Birth control pills.
Yeah, birth control pills. So what does this all mean for the patient?
Hmm.
We are using a contraceptive pill not primarily for birth control, but as what? A preventative cancer shield and a hormone regulator.
Yes. The use of the pill here is so often misunderstood. Societally, we really view oral contraceptives almost exclusively through the lens of, family planning.
Right, pregnancy prevention.
But in the context of PMOS, the pill is doing some massive physiological heavy lifting. Like you said, it's a hormone regulator and, crucially, a preventative cancer shield.
Cancer shield is a strong term. I really want to break down the mechanics of why that is necessary, because the text focuses heavily on chronic anovulation, right? The fact that the ovaries are not releasing an egg each month.
Right. So to understand the danger there, we have to look at a normal menstrual cycle.
Okay.
Typically, your body produces estrogen to thicken the uterine lining, the endometrium, creating this nutrient-rich environment for a potential egg. Once ovulation occurs, the body produces progesterone, and progesterone acts as the stabilizer for that lining. If a pregnancy doesn't happen, the progesterone levels drop, the lining destabilizes and sheds, and that is the menstrual period.
But in this syndrome, the ovulation never happens, so that progesterone stabilizer just never arrives.
Never arrives. You are left with continuous, unopposed estrogen. The body just keeps thickening that uterine lining, month after month after month.
Oh, wow.
And over time, that unchecked, unstable cellular growth leads to endometrial hyperplasia, which is a precursor to endometrial cancer.
That's terrifying.
It is. So by prescribing a combined oral contraceptive, the doctor is providing a daily dose of synthetic progestin. That progestin artificially steps in to antagonize the estrogen. It stops the runaway thickening, keeps the lining thin, and eliminates that cancer risk.
That reframes the pill completely. It's literally maintaining the structural integrity of an organ.
Exactly.
But the documents do stress that this systemic intervention comes with systemic risks, right?
Yeah.
Particularly VTE.
Venous thromboembolism, yes.
Right.
That refers to dangerous blood clots forming deep within the veins. When you introduce synthetic estrogen into the body, it passes through the liver, and it can actually increase the production of certain blood clotting proteins.
Okay.
For a young, healthy patient, that slight increase is usually totally negligible. But the sources urge extreme caution for a very specific demographic: women with a body mass index of 30 or higher who are over the age of 40.
Because if a patient is over 40 and dealing with obesity, their baseline vascular resistance and systemic inflammation are already elevated. Adding synthetic estrogen to that environment could just, I guess, tip the scales toward a clot.
Exactly. The physician has to carefully weigh the invisible risk of a blood clot against the invisible risk of endometrial cancer.
Wow, what a balancing act.
It really is.
Yeah.
And beyond that internal balancing act, the pill is also the first line of defense against the visible, often really distressing symptoms of androgen excess.
Right.
Hirsutism.
The unwanted facial and body hair growth.
All right.
But how does the pill actually stop the hair growth?
Well, it acts kind of like a sponge. The estrogen in the contraceptive pill stimulates the liver to produce a specific protein called sex hormone-binding globulin.
Okay.
That protein floats through the bloodstream and physically binds to the free-floating testosterone, just locking it up so it can no longer interact with the hair follicles.
Oh, that makes sense.
But this requires immense patience from the patient.
Yeah, reading the guidelines, they say a patient must wait a full 6 months on the pill before a doctor will even evaluate if it's working for the hair growth.
Right.
I mean, if you are the patient dealing with this visible symptom every single day, 6 months feels like an eternity.
It is agonizingly slow.
Oh.
But it's dictated by the biological reality of hair growth cycles. The hormonal shift happens internally right away, but you have to wait for the existing stimulated hair to naturally complete its life cycle, fall out, and then be replaced by new follicles developing in that lower testosterone environment.
Wow. And if 6 months pass and it's still not working...
Then the standard of care moves to adding an anti-androgen medication, like spironolactone.
Right. But the text slaps a massive warning label on anti-androgens. They must absolutely always be paired with highly effective contraception.
Yes, because the mechanism of spironolactone is to actively block male hormones at the cellular receptor level.
Right.
If a patient taking that medication were to unexpectedly become pregnant with a male fetus, the drug would cross the placenta and severely disrupt the normal development of the fetus's external genitalia.
That is a profound risk.
It is, which is why those two medications are inextricably linked.
Okay, so we've covered how to shield the uterus and bind the hormones,
Mm.
but treating hormones with other hormones, it's essentially just mopping the floor while ignoring the broken pipe that's frying the basement, right?
That analogy, yes.
The sources point to the metabolic system as the broken pipe, specifically weight and insulin. And here's where it gets really interesting, because we see a massive, highly consequential shift in medical guidance regarding a drug called metformin.
Yeah, the demotion of metformin is honestly one of the most striking elements of these clinical updates. It's a masterclass in how medical science relies on cumulative data to self-correct.
Right, because for anyone who might have PCOS or know someone who does, metformin has been a household name for decades.
Oh, absolutely.
It was prescribed for weight loss, fixing menstrual cycles, lowering testosterone. Millions of women have relied on it, but this document completely benches it, like a former MVP athlete. It is now strictly considered a second-line therapy.
Yeah. The clinical data just finally reached a critical mass that could no longer be ignored. When researchers looked at massive swaths of outcomes, metformin was only restoring menses in about 30 to 50% of patients.
That's not great, no.
And for symptoms like hirsutism, the Endocrine Society now explicitly advises against using it because the benefits are statistically negligible compared to oral contraceptives.
Yeah.
It just doesn't do the heavy lifting we assumed it did.
So, if the supposed magic pill isn't the answer to the flooded metabolic basement, the guidelines point straight to weight loss. But the threshold mentioned is surprisingly accessible.
It really is.
We aren't talking about massive transformations here. A 5 to 10% reduction in body weight can be enough to turn the biological system back on and restore normal ovulatory cycles.
And if we connect this to the bigger picture, to understand why that relatively small percentage makes such a difference, we have to look at how insulin drives the entire syndrome.
Okay, lay it out for me.
The core underlying issue for most of these patients is insulin resistance. Their cells have essentially locked the doors, refusing to let glucose in for energy.
Right.
So the pancreas responds by pumping out massive, continuous surges of insulin to try and force those cellular doors open.
And those high insulin levels don't just stay in the bloodstream, right? They travel directly to the ovaries.
Exactly. They flood the ovaries, they bind to receptors and command the ovarian tissue to overproduce testosterone. That is the cascade. So when a patient loses even a small amount of weight, it physically alters the insulin sensitivity of their cells. The doors unlock easier, the pancreas stops surging insulin, the floodwaters recede, the ovaries calm down, and the testosterone production drops.
Which brings us to, honestly, the most surprising data point in this entire document, especially if you spend any time scrolling through health and wellness content online.
Oh, the diet advice.
Yes. If you search for PCOS diets right now, you will be hit with an avalanche of voices claiming you must eat a strictly low-carb, high-protein diet to control your insulin. But the sources highlight a specific 12-week study that puts that internet theory to the test.
Yeah, the macronutrient study. They took patients and split them into two groups. One eating a high-protein, low-carb diet, another eating a low-protein, high-carbohydrate diet. But both groups were placed in a calorie deficit.
And the results showed that the diets were exactly equally effective. Both groups saw the same weight loss, the same improvement in insulin resistance, and the same restoration of menstrual cycles. The specific macronutrients, the carbs versus the proteins, did not matter.
No, they didn't.
The only thing that mattered was the calorie deficit. I was really surprised by that.
It is a phenomenal reminder that energy balance dictates biological prioritization. By simply reducing the total energy entering the system, the body was forced to draw on its reserves. And that inherently lowered the overall insulin demand.
Right.
It didn't matter if that energy came from a carbohydrate or a protein. The deficit itself is what drained the metabolic floodwaters.
Now, for patients where lifestyle interventions aren't moving the needle, the data on bariatric surgery is astounding. A randomized trial showed that women who had a laparoscopic sleeve gastrectomy were 2.5 times more likely to resume spontaneous ovulation at the 52-week mark compared to women relying on medications like metformin.
Because a sleeve gastrectomy isn't just about making the stomach smaller. It triggers a profound, immediate reset of gut hormones that communicate directly with the pancreas and the brain.
Wow.
It physically rewires the metabolic signaling. It just proves, again, how interconnected these systems are.
And that interconnectedness shows up again in a totally different system, the respiratory system. The guidelines carve out a significant section on obstructive sleep apnea, which is highly prevalent in this patient population.
Yeah, we traditionally view breathing problems and hormonal problems as existing in, like, completely separate medical silos.
Right, totally unrelated.
But consider what happens during sleep apnea. The patient stops breathing momentarily. Their blood oxygen drops. The brain panics, assuming it's choking, and floods the bloodstream with acute stress hormones, cortisol and adrenaline.
And those stress hormones are designed for fight or flight survival, not digestion. So they actively block insulin from doing its job, making the insulin resistance even worse.
Exactly. So by treating the sleep apnea with a CPAP machine, literally just blowing continuous air to keep the airway open at night, you turn off the brain's panic alarm.
Okay.
The cortisol and adrenaline clear out.
Okay.
And without that chemical interference, the patient's cells become physically more sensitive to insulin the very next day. Just by breathing normally at night, their body processes sugar better.
That is mind-blowing.
It is.
Yeah.
The documents also link this metabolic chaos to MASLD.
Oh, metabolic dysfunction-associated steatotic liver disease. Just to clarify, that is the updated medical term for a fatty liver that is caused by metabolic and insulin dysfunction rather than alcohol consumption.
Right. The excess insulin forces the liver to store fat abnormally.
Right.
It all traces back to that exact same metabolic engine.
Okay, so we have spent a lot of time mapping out how to stabilize this engine for daily maintenance, right? Managing the insulin, shielding the uterus, clearing the hormones. But the guidelines completely flip the treatment paradigm upside down when the patient says, I am ready to try for a baby.
Totally different goal.
Because the goal moves from managing a chronic baseline to triggering a highly complex singular biological event, ovulation.
And you cannot simply flip a switch to make that happen. You really have to prep the biological terrain first.
The contrast between the two major clinical trials detailed in the text illustrates this beautifully. Let's look at the PPCOS2 trial versus the OWL PCOS trial.
Okay.
In the PPCOS2 trial, they took patients and immediately administered an ovulation-stimulating drug called clomiphene. They just rushed straight to the medication, and the result was a 45% ovulatory rate, but a deeply disappointing 10.2% live birth rate.
Because the medication provided the spark, but the metabolic engine was still flooded with insulin and androgens. So the spark couldn't ignite a sustainable pregnancy.
Right. Now look at the OWL PCOS trial. They took a completely different approach. They withheld the medication and required a 16-week lifestyle intervention first, focusing on diet, exercise, and behavioral modification.
Prepping the terrain.
Exactly. The patients achieved an average weight loss of just 6.5%. And only after that prep period did they introduce the medication. The ovulatory rate jumped to 62%, and the live birth rate more than doubled to 25%.
It proves that the ovarian follicles have to be able to hear the medication.
Oh, I like that.
Yeah, by lowering the body weight just a few percentage points, the insulin and testosterone levels dropped enough to quiet the systemic noise. So when the drug was finally introduced, the body was actually receptive to the signal.
Though the text does carve out a fascinating, highly specific exception to this rule of prepping the terrain.
Right, the age factor.
Yeah. For patients who are 37 or older, or for patients whose testing shows a diminished ovarian reserve, doctors are instructed to skip the weight loss prep entirely and go straight to the medication. Biological time becomes the overriding risk factor, superseding the metabolic optimization.
It is a stark reminder that medicine is always a calculated risk assessment, based on the individual's most pressing biological constraint.
Speaking of those medications, there is a massive shift in the new standards of care here, too. For decades, clomiphene was the undisputed gold standard for inducing ovulation.
Oh, yeah, everyone knew clomiphene.
Right. But the new first-line drug is letrozole, because the data shows it consistently leads to higher live birth rates. But what stands out here is that the document explicitly notes letrozole is an FDA off-label use for this purpose.
This happens frequently at the cutting edge of clinical practice, actually. Letrozole was originally developed as a breast cancer treatment to suppress estrogen.
Okay.
But researchers discovered that temporarily suppressing estrogen tricks the brain into pumping out more ovulation signals.
Wow.
The clinical data on its efficacy and safety in producing live births in PMOS patients is just so overwhelmingly superior that it's become the standard of care globally.
Yeah.
even though the bureaucratic regulatory labeling hasn't officially caught up to the science yet.
Now, if the medications fail to trigger ovulation, the text moves to surgical options as a second-line treatment. And I have to admit, reading the description of this procedure, it feels like reading a manual for a medieval torture device.
Laparoscopic ovarian drilling.
Yes. The guidelines describe taking a 40-watt laser and making 3 to 6 actual punctures deep into the ovary, holding the thermal energy there for 4 seconds per puncture. Wait, drilling into the ovary. We are taking a laser drill to the exact reproductive organ we are trying to heal.
I know, it sounds awful.
How does creating literal physical damage magically fix a delicate reproductive cycle?
On the surface, it sounds incredibly destructive. But it's actually a brilliant manipulation of the underlying pathology. Think about what that polycystic ovary looks like structurally.
Okay.
It is swollen and engorged with excessive stromal tissue. That extra tissue acts like a smog factory, chronically overproducing local androgens that create a toxic environment, essentially smothering the healthy follicles.
So the surgeon is going in to physically burn away the smog factory.
Exactly. By destroying a highly calculated portion of that androgen-producing tissue, the local testosterone levels instantly plummet. And to understand why that matters, we have to look at the brain.
Right, the signals.
Your brain is trying to send down two vital messenger hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, FSH. Their job is to tell the ovary to release an egg, but the hormonal smog blocks them.
Wow.
Once the laser clears that tissue, the smog lifts. The LH and FSH finally reach the follicle, the signal gets through, and the patient ovulates.
That is wild, and the success rates listed are astounding. Following this thermal damage procedure, ovulatory cycles occur in approximately 80% of patients, and the effects can normalize their cycles for years.
It is essentially a hard reboot of the reproductive hardware.
But if neither the medications nor the surgical reboot are successful, the final escalation is in vitro fertilization, IVF. And here is where our benched medication, Metformin, makes a highly tactical return to the field.
Yes, Metformin finds its redemption in the IVF clinic, because patients with this metabolic profile face a uniquely high risk for a severe complication called ovarian hyperstimulation syndrome, or OHSS.
Because in a typical IVF cycle, the patient is injected with powerful hormones to stimulate the ovaries to produce as many eggs as possible, right?
Right.
But because the polycystic ovary already contains dozens of stalled hypersensitive follicles, it can violently overreact to those drugs. The ovaries swell dangerously, and fluid begins leaking out into the abdominal and chest cavities.
It is a critical, potentially life-threatening complication. But the clinical data reveals that if doctors administer metformin before and during the IVF stimulation phase, it acts as a stabilizing agent within that local ovarian environment.
Okay.
It doesn't improve the actual pregnancy rates of the IVF cycle. But for women with a BMI over 26, it lowers the risk of developing that severe hyperstimulation from 18% down to 10%.
That's a huge drop.
It is. It's a highly specific protective use of a drug that was once treated as a universal cure-all.
The guidelines also make a point to clear the board on alternative therapies that patients frequently ask about. The sources explicitly state that despite their popularity, neither acupuncture nor inositol supplements show any clinical evidence of improving live birth rates.
Right.
When patients are desperate for a family, they will often spend thousands of dollars on adjunctive therapies, but the data simply doesn't support them for this specific goal.
Yeah, when you are dealing with a system this complex, you really have to follow the verified mechanisms, not the marketing.
Absolutely. Well, this has been a massive journey through the clinical realities of a deeply misunderstood condition. To synthesize what we've uncovered from these sources, the disease we know as PCOS is dangerously misnamed. It is a fully integrated polyendocrine and metabolic syndrome. Because it is systemic, the interventions have to be systemic. Whether a doctor is prescribing oral contraceptives to artificially shield the uterus from cancer, utilizing a CPAP machine to clear the stress hormones that block insulin, or using a laser to burn away the hormonal smog in an ovary, you cannot fix the vehicle by only staring at the tires.
The overarching lesson here is that human physiology refuses to be compartmentalized. We have to treat the body as a deeply interconnected ecosystem.
As we close out this analysis of the clinical guidelines, what is the final provocative thought you are left with? What should people listening take away to explore on their own?
You know, if the name Polycystic Ovary Syndrome successfully misled patients, researchers, and physicians for decades by hyper-focusing their attention on one localized symptom, How many other medical conditions are currently holding us back simply because they are misnamed?
Oh.
If we truly started viewing the human body as an unbroken metabolic network, what other mysterious, incurable, localized conditions might actually just be systemic imbalances sitting right there in plain sight, just waiting for a rebrand?
That is a profound question to leave on. Thank you for joining us on this
Huh.
deep dive.